Hello, good evening, and welcome to our webinar this evening with Boston IVF. I am Dr. Kristen Wright. I'm the medical director and physician at Boston IVF in our New Hampshire office. And I'm here today to talk to you guys about polycystic ovarian syndrome, which is a super common reason for infertility that we see frequently. So I'll start with a maybe 10-minute overview or so about what PCOS is, how we make the diagnosis, what the implications of the syndrome are, and then ways that we can address and treat this. Um, and then after that overview, I am happy to hear your questions and know what you want to know about PCOS and answer what I can for you. So you can enter questions as we go along here, and I'll get to those. But just to start with an overview, polycystic ovarian syndrome is the most common reason for a reproductive age woman to have an irregular menstrual cycle. So when we say an irregular menstrual cycle, women who have a regular cycle will typically have a period between 24 and 35 days. So approximately once a month. Again, range can be 24 to 35 days. Some women are on the shorter side, some women are on the longer side. If you are having a predictable period like that, that tells us that you're ovulating and releasing an egg every month. If you are having an irregular cycle, then you are not ovulating and releasing an egg every single month. And the type of bleeding that women with PCOS can have can vary. Some women with PCOS don't ever get a period at all. It's just very rare that anything happens. Other women have irregular, completely unpredictable bleeding. Sometimes it's light, sometimes it's heavy. They never know when it's going to happen. Sometimes it's happening frequently throughout the month. Other women with PCOS have what seems like a normal period, but it's happening infrequently. So sometimes it's every 45 days or every 60 days that they're getting a period. So any of those patterns would qualify as an irregular menstrual cycle. If you have a regular menstrual cycle, then you don't meet diagnostic criteria for PCOS. So you don't have PCOS unless you have an irregular cycle. The other two things that we would look for to make a diagnosis of PCOS, you would need to have either a polycystic appearance of the ovaries on ultrasound, and that's something that we can look at and diagnose using a transvaginal ultrasound. Some women, when they hear polycystic ovarian syndrome, think that we're talking about very big cysts on the ovaries, but it's actually little tiny cysts that we're looking for on the ovaries, and they have this very classic appearance. So the ovaries aren't usually super enlarged in PCOS, but they have this classic polycystic appearance. The other way that you can make the diagnosis of PCOS is looking for evidence of high androgen levels. So androgen levels, the one people are most familiar with is testosterone. All women's ovaries make testosterone, but women with PCOS make it in higher amounts. And that's actually what causes the block of ovulation from happening. So we can measure testosterone and other androgen hormones in the blood. We can also ask if you have symptoms of high androgen levels. Symptoms of high androgen levels would be things like hair growth, like on the face or on the body, or acne is a sign of high androgen levels. And some women will even get alopecia, which is male pattern baldness that can happen with PCOS. So any of those things would be signs of hyperandrogenism. The other thing that we would need to do when we're diagnosing PCOS is to rule out other causes for PCOS, or for an irregular cycle, rather. So abnormalities in the thyroid hormone or in the prolactin hormone can also cause menses to be irregular. So those should be measured to make sure that that's not the cause for the irregular cycles. Other things that can cause an irregular cycle are nutritional issues. Women who are very underweight will often have the reproductive hormones shut off as a defense mechanism in response to being underweight. We see this commonly in college athletes or women with restrictive eating habits or eating disorders. That can also be evaluated with blood work. And then sometimes women with extreme obesity also have irregular cycles, but don't actually have PCOS. So that's all things that we would ask women about when we're making this diagnosis, and then do the appropriate laboratory and ultrasound testing to see if you meet criteria for that. 5 to 8% of women have PCOS. So again, it's a super common syndrome that we see. And it varies in severity. Some of the things that can go along with PCOS, if you have a diagnosis of PCOS, you are at increased risk for so-called metabolic syndrome later in life. So that's increased risk of developing diabetes. That can be gestational diabetes or type 2 diabetes. You're also at risk for developing high blood pressure or high cholesterol. There's lots of things that affect that risk. Not everybody with PCOS gets those things, and certainly plenty of women without PCOS get those things. But it's important to be aware that women with PCOS are at higher risk and should be screened appropriately during their lives to look for those things. So how do we treat it? Well, our goals for treatment are going to depend upon whether the goal is to have a baby or to not have a baby. The problem with PCOS when you're not ovulating and releasing an egg every month is that you're not making the hormone progesterone. And the hormone progesterone is really important in protecting the lining of the uterus from developing abnormal cells. The progesterone hormone works to stabilize the lining of the uterus and then allows it to shed in a regular fashion. When that's not happening, the lining can build and build and build. And over time, you can start to develop abnormal cells inside the uterus that can ultimately progress to uterine cancer. We can prevent that from happening by giving you progesterone. The easiest way to give people progesterone is to use birth control pills. Some women with PCOS come in sort of frustrated because they're like, why can't someone treat my PCOS? They just keep telling me to take the birth control pill. Well, the reason that you're being told to take the birth control pill is because that progesterone is to protect the lining of the uterus. If you don't like taking birth control pills, due to side effects, contraindications, whatever it is, there's lots of ways to take progesterone. The other ways to take progesterone would be to use a progesterone-only pill, and you can take that either throughout the month or just for a couple of weeks during the cycle. Other ways, there's implants that can be placed. There's vaginal rings. There's also an IUD, which is very popular that a lot of women really like, that goes inside the uterus. And typically women with a progesterone releasing IUD don't get their periods, but that's okay because their uterus is seeing that progesterone and that's protecting the lining of the uterus from developing those abnormal cells. So when you're not trying to conceive or when you're between pregnancies, being on some sort of progesterone is very important for you. If you are trying to have a baby, which will probably be a lot of people in this audience, then we mostly just have to get you to ovulate. We will typically do a full fertility evaluation for women, even when they have a diagnosis. We know that they have a diagnosis of PCOS, just rule out other causes for infertility. So we want to make sure that your fallopian tubes are open. We want to make sure that there's sperm present, assuming that you're conceiving with a male partner. But if all of those things are checking out okay, then a vast majority of women with PCOS will be able to ovulate and get pregnant using a medication called Letrozole, which is the most common oral medication that we use for women with PCOS. It's an oral pill. It's usually pretty well tolerated. You take it for 5 days out of the month. A vast majority of women, as I said, will ovulate in response to letrozole and often be able to conceive just using timed relations at home. If that doesn't work, or if there's other fertility factors going on, then there's certainly more advanced types of treatments that we can also do. We can do what's called IUI, which is placing sperm into the uterus. That stands for intrauterine insemination. Or we can do IVF, which is a more advanced type of treatment, more involved, but also typically has a much higher success rate. Things that we would take into consideration making a treatment plan for you would include your age, other fertility factors, family size goals, as well would be discussed with your doctor before we make the appropriate treatment plan for you. So that's just a quick overview on PCOS. I'm going to open the questions now and see what you would like to know. So the first question I have is, does PCOS affect IVF success? Yes, somewhat. So when women with PCOS go to IVF, On average, they make more eggs than women without PCOS because most women with PCOS have a very high ovarian reserve. So they typically make more eggs than someone who doesn't have PCOS. However, we tend to see more variability in egg quality in women who have PCOS who go to IVF to conceive. And presumably, many women who go to IVF have often already tried letrozole and ovulated a few times and not become pregnant, and that's why they've moved on to IVF. So not everybody with PCOS has variability in egg quality, but that is something that we see not infrequently at the time of IVF. Fortunately, the success rate is still very good. It's about the same as a woman without PCOS because we typically get about the same number of good quality embryos. And it's the good quality embryos that predict your success rate with IVF. And most women with PCOS are able to have successful implantation and deliveries with IVF. All right, the next question I have is, how can I minimize my risk of miscarriage with PCOS? Can it cause miscarriage? So the short answer is yes. Women with PCOS do have a higher miscarriage risk than women without PCOS. We don't completely understand exactly why that is. It's probably multifactorial. The things that you can do to reduce your miscarriage risk, if insulin resistance is present or a prediabetes state, which can be measured, that's a test that we can do blood work for to see if you have that. If you have insulin resistance, then there's some evidence that treating that either with lifestyle modifications or with medications can reduce your miscarriage risk. Most commonly, we would use a medication called Metformin for women with insulin resistance, and that might be helpful in reducing miscarriage in women who have that. Metformin is not always super well tolerated. So if you don't tolerate metformin, you can also use, it's actually sold as a supplement in this country called Myo-Inositol. And that also treats insulin resistance reasonably effectively. So those are things that you can do preconception to help to address that will reduce your risk of miscarriage. The other factor at play in women with PCOS is that women with PCOS do have higher risks of obesity, and obesity can also increase miscarriage risk. So if you're young and able to achieve some weight loss before conceiving, that can also help to reduce your risk of miscarriage. We do typically prescribe progesterone if we're doing IVF for women with PCOS because that progesterone hormone is very important for them. All right, so I have, is there a blood test for PCOS? There's blood testing that we would do for PCOS, yes. The blood testing would involve looking at your reproductive hormones. So that's looking to make sure that you have good numbers of eggs in the ovaries. Typically, women with PCOS have very high numbers of eggs in the ovaries. And then the androgen hormone levels that are part of how we make the diagnosis of PCOS would usually be screened for. And if those are elevated, that supports the diagnosis of PCOS. And then the other thing that we need to do with blood work is to rule out other causes for PCOS. So abnormalities in thyroid or prolactin hormone should be checked. There's something called congenital adrenal hyperplasia, which is different from PCOS, but can mimic PCOS. And we can test for that to rule that out. If you have that, then the treatment for helping you to ovulate is a little bit different. So there's definitely blood testing involved. But it also involves taking a history, so asking you what symptoms you're having, doing the appropriate blood work, and then usually an ultrasound as well to help us make that diagnosis. Next person says, I have my first appointment with you in October. Fantastic. I look forward to seeing you. The next question says, I have a semi-regular menstrual cycle, 25 to 45 days. Polycystic ovaries on ultrasound, high androgen levels, insulin resistance, and many of the other symptoms of PCOS. I was diagnosed with PCOS, but is this a false diagnosis if I have cycles within every 45 days? So it sounds like your cycles are sometimes a little bit longer than what we would typically see with an ovulatory cycle. But it is possible that you're ovulating. You're just ovulating a little bit less frequently than you ideally should be. Um, Not all bleeding means that you're definitely ovulating, especially if it's a little bit less regular than it should be. So there are some tests that we could do to see whether you are in fact ovulating. One thing that you could do at home is to do like an ovulation predictor kit and see if you got a positive. If you've ovulated, you should get your period 2 weeks after that ovulation. It might be a little bit tricky for you to do ovulation predictor kits just because it sounds like your cycles are a little bit variable. And there may be some cycles where you are ovulating and some cycles where you're not ovulating. Some of those longer cycles, you may not actually be releasing an egg. The lining of the uterus just kind of builds up sometimes, and then will eventually shed without having ovulated. So it's possible. It sounds like my guess would be that some of your cycles are ovulatory, and some of them are not. So I think that you have PCOS. It may be a more mild version of PCOS. It's certainly variable in how it presents and in the symptoms that we see. So you may just have a more mild version of this. Using letrozole will help to regulate that cycle so that you can have more chances for pregnancy if that is your goal. So this next person says, I have had gestational diabetes 5 years ago and I've had several losses. I'm sorry to hear that. What should I expect with my first appointment with my husband? So with a history of gestational diabetes, you're at increased risk for type 2 diabetes. So we would screen for that just to make sure that that's not present. If you have insulin resistance, which you certainly may, then we would talk about treating that with the appropriate medications. And then if you're having losses, there is a workup that we would do for recurrent pregnancy loss. So typically after 2 losses, there's some additional testing that we would do to see if we can determine a reason for those losses. So we would want to do a good uterine cavity evaluation where we look inside the uterus to make sure there's no polyps, fibroids, or scar tissue that could be contributing to the losses. Sometimes women will have what's called a septum, which is a congenital thing that people are born with. So we would rule that out. And then we would also do blood testing for you to see if you're looking at immune factors. We would look to see if you're at increased risk for forming blood clots behind the placenta. If we see signs of that on blood testing, then we can treat you with heparin in the first trimester of pregnancy, and that would improve your ability to carry the pregnancy. And then we would also check karyotypes for each of you. That's looking at your chromosomes to make sure that you don't have a chromosome rearrangement that could be causing issues with either the eggs or the sperm, and that's also done with blood testing. So at your first appointment, we would talk about your history and what's been going on with you. And then we would also do the appropriate either ultrasound testing as well as lab work to see what's happening. So I look forward to seeing you. Just want to make sure my headphones are still working. Yeah, okay. Next question says, I received a diagnosis of PCOS when I was younger due to irregular periods lab results. As I've gotten older, my periods have naturally regulated itself, normal every month. However, my lab results continue to indicate PCOS. Does this improve egg quality chances? So this can happen in women with PCOS. As women get older, the ovaries will naturally produce less of the androgen hormones, less of the testosterone hormones. And so that block on ovulation sometimes goes away as those hormone levels go down. And so women sometimes do see regulation of their periods later in their reproductive years. You probably do still have some laboratory signs of PCOS if you've had it in the past, so that's not surprising. I think you would have a chance of becoming pregnant on your own, for sure, without necessarily needing fertility treatments. It's hard to comment on egg quality. The fact that your periods have regulated suggests that this is a more mild form of PCOS, so hopefully the egg quality would be okay. There's lots of things that influence that. Age is strongly predictive of egg quality, so that's a factor to consider. And then overall health, so things like obesity and general lifestyle things also impact egg quality. So I encourage you to to have a healthy lifestyle. Trying to conceive on your own, I think, is reasonable. That's not it's not happening. Then come see us and we can help things along for you. Um, Next question. If I have PCOS and ovarian hyperstimulation syndrome, how would that affect my fertility treatment plan? So this sounds like a history of what's called ovarian hyperstimulation syndrome, which is a complication of IVF. We don't see this complication nearly as frequently as we used to. Ovarian hyperstimulation is a condition where when the estrogen levels get to be very high during IVF stimulation, which can happen pretty commonly in women with PCOS, what happens is that it causes the blood vessels to get leaky, and you can accumulate a bunch of fluid either in the abdomen or around the lungs. We sometimes have to do surgical procedures to drain that fluid or even admit you to the hospital in severe situations. We used to see this pretty frequently. It usually get complicated about 1% of IVF cycles. So we do a lot of IVF cycles, so we saw it a lot. There have been improvements in the way that we do IVF, specifically avoiding HCG hormone. In most cases, will dramatically reduce, if not eliminate, the risk of ovarian hyperstimulation syndrome developing. So instead of using an HCG to trigger the final maturation of the eggs, which is the trigger that we most commonly use, we would use a different trigger called Lupron. That Lupron trigger is usually very successful in triggering the final maturation of the eggs, and dramatically reduces the risk of developing ovarian hyperstimulation syndrome. And then the other thing that we would do if you've had a high response to IVF is to freeze your embryos. If you become pregnant, your body will make HCG hormone, and that will cause a risk of ovarian hyperstimulation syndrome. But if you don't become pregnant immediately after the IVF because we freeze the embryos, then the risk of ovarian hyperstimulation syndrome essentially completely goes away. So a common approach for women with PCOS would be to use a Lupron trigger and then to freeze all of the embryos so that you don't run that risk of developing that particular complication. We would look at your blood test hormone levels to make the IVF plan that's most appropriate for you. Does reducing stress levels for ladies with PCOS help manage PCOS? And what does stress level reduction look like? So stress is not good for anything, health-wise, but it's pretty impossible to completely eliminate stress from your life. And going through infertility and fertility treatments is certainly a very stressful process. I don't think that your stress is causing your PCOS. So while I would encourage you to address the stress that you're feeling, that's not necessarily going to correct the syndrome. It's not the cause there. There's not one way to reduce stress, unfortunately, but there's lots of things that can be helpful. Many people find acupuncture to be helpful, and we have fertility acupuncturists in the various communities that we can recommend to you. Many women find that to be very helpful. Some women find counseling therapy to be helpful. Taking time, I encourage everybody to take some time during your day to do something, for yourself. Meditation, those kinds of things can be helpful for stress reduction. And then I also think that physical activity is really important for reducing stress. It also helps to improve sleep if you're more physically active. So I would encourage you to do those sorts of things, but don't beat yourself up for feeling stressed either, because again, I don't think that that's causing the PCOS, although I certainly encourage you to address it as best you can. All right, next question. What if Letrozole and Clomid stop working? Trying for a second, a year in, and my body isn't responding anymore to the meds. So that can happen. Ovulation induction medications in the published literature, between 60 and 80% of women with PCOS will ovulate in response to oral medications like letrozole or Clomid, but 20% or more don't. So it is something that we do see sometimes. There's a couple of options to consider. We can try to use some additional oral medications to sensitize your body to the letrozole or to the Clomid. The things that we would consider there would be metformin or inositol, which I mentioned earlier, which can address insulin resistance, and that does help to sensitize the body to letrozole or to Clomid. The other oral medication that can be helpful is to use low-dose steroids. Low-dose steroids will reduce the circulating androgens, which is what's causing the block on the ovulation. And so sometimes that's enough to allow the letrozole and the Clomid to then kick in and work. I've had success with that approach. So those are options if you want to stay with more conservative treatments. And that may or may not work. There's kind of 50-50 chance that adding those medications is going to help you to ovulate. So it could go either way. The more effective treatment would be to move on to IVF. IVF is a more involved process, obviously, but it typically would give you a significantly higher pregnancy rate than just continuing the ovulation induction medications. So that would be, a discussion for you to have with your doctor about which approach you would like to take. We technically can use IVF medications to help you to ovulate, but we don't typically do that treatment very much anymore, just because of the medications that we use with IVF are very powerful medications. And there's a very high risk of multiple birth pregnancy, so very high risk that you're going to release more than one egg and have a multiple birth pregnancy if we use those medications just to help you to ovulate. So that's not typically done very much anymore. It's a lot safer to use those medications in the context of an IVF cycle where we have a lot more control over the process, and we would be able to transfer just one embryo at a time to the uterus to make a pregnancy. Plus the success rate would just be a lot higher with IVF as opposed to anything else. So I hope that that's helpful and that one of those things can be considered for you. Next question. Is it true that LH testing with strips is misleading for women with PCOS? And how can we accurately measure if we are ovulating or ovulated already other than monitoring basal body temperature? So yes, it is true that ovulation predictor kits can be falsely positive in women with PCOS. Women with PCOS tend to have elevated LH hormone levels as compared to women without PCOS. And the LH hormone is also the hormone that triggers ovulation to happen. So that's what the ovulation predictor kits look for, is that LH hormone. But if the LH is always high, then your ovulation predictor kit is always going to be high. So if you're finding that the kit is positive every day or multiple days in a row, then that's a sign that this is a false positive. Usually the ovulation predictor kit should turn positive about 2 weeks before you get your period. So if you're not noticing that pattern, then that indicates that you most likely have had a false positive result. The ways that we can check to see if you've ovulated without using ovulation predictor kits, the easiest way is to use a progesterone level, to check a progesterone level after ovulation has happened. So typically about a week after we would have expected ovulation, we can check the progesterone hormone and see if it's elevated. If it's positive, then that would tell us pretty conclusively that you have ovulated. You can also do follicular monitoring, which would be ultrasound and blood work that we would do in the middle of the cycle to see if you're developing a follicle. And then if you're trying to conceive, we can actually trigger you to ovulate at a specific time. So those are other things that we can do to determine whether or not ovulation is happening. Next question is spotting 2 to 4 days before my period a symptom of PCOS or more likely just a progesterone issue. I currently take progesterone after cycle day 14. So the answer is it depends. Late luteal spotting like that can be a normal bleeding pattern. The things that we would think about that could be causing that would be low progesterone levels, but it sounds like you're already taking progesterone, so that's less likely to be an issue if you're taking the progesterone. Um, Other things that can cause spotting like that would be structural problems in the uterus. So if there's a polyp, either in the lining of the uterus or in the cervix, that can cause spotting to occur. And then something called endometritis, which is inflammation in the lining of the uterus, can also cause spotting like that to occur. So typically when there's abnormal bleeding or spotting in the middle of a cycle, of an ovulatory cycle, we would do further evaluation to see if there's a structural reason for that and to see if there's any inflammation that's causing that spotting to happen. If we rule that out, then we would conclude that it's most likely a hormonal issue, although the treatment for that would be to take progesterone, which it sounds like you're doing already. Typically, progesterone is most effective if you're also using one of the oral medications like letrozole or Clomid. So I hope that is helpful for you. Next question. How far into the pregnancy do you generally recommend taking the metformin in someone with PCOS and insulin resistance, but no diagnosis of diabetes? That's a good question, and it's somewhat controversial. The official recommendations from like ACOG, American College of OBGYNs, and ASRM, which is the American Society for Reproductive Medicine, is to stop the metformin with a positive pregnancy test. So that is what I typically recommend. With a history of insulin resistance, you are at increased risk for developing gestational diabetes and should be screened for that early in the pregnancy. Some people continue metformin into the first trimester. The thought is that there was some thought that might reduce the risk of first trimester miscarriage. The data in the published studies haven't really shown that to be the case. So there's not a clear reason to continue metformin into the first trimester of pregnancy. And we always obviously want to be a little bit careful about prescribing medications during pregnancy because we don't want there to be risks to the baby. There's no known risks to the pregnancy with metformin, but it's something that we would be a little bit careful about. So typically we stop it with a positive pregnancy test is usually what we would do. Next question, can you please explain the different types of testing you can have on the embryos? So yes, if you do IVF, there's different testing of embryos that we can do. Most commonly, we do something called PGTA testing. That's an extra step in the IVF process where we would biopsy the embryos to see which embryos have chromosome problems and which don't. Many embryos look fine and normal to us in the petri dish, but have underlying chromosome problems such that they're not going to make a successful pregnancy. We can't tell that just by looking at the embryos, but we can tell that if we do a biopsy. So the advantage of that testing is that it screens out embryos, abnormal embryos, so that we don't spend time transferring them. That reduces the risk of miscarriage, also reduces the risk of having a child with a serious chromosome problem. So that's the most common type of testing that we do. That testing is helpful in women with PCOS because we do see some variability in egg quality in women with PCOS. That helps us to screen out those abnormal embryos so that you don't waste time transferring them if they're not going to be successful for you. There's other things we can test embryos for. If you both carry a gene for the same recessive genetic condition, which is usually something that we would screen you for at the first appointment, then embryos can be tested for those individual conditions. If there's a structural arrangement in your chromosomes that's causing multiple miscarriages, that can also be screened for in the embryos. And then finally, when we're deciding on which embryo to transfer, there's a grade that we give to the embryo, and that grade is just based on the appearance of the embryo in the petri dish. So we would look at that grade to determine which embryos are best for you and which ones to transfer first. And not sure what that question is saying, so in your next question, in your experience, is it common that women with PCOS have better results with, I think this is IUI, than with artificial insemination? In my case, I'm lesbian, need sperm from a donor. IVI. So, okay. So I think this participant is asking us whether doing inseminations at home versus like an IUI where we put sperm into the uterus would be better. Um, the answer is that if you're using frozen sperm from a sperm bank, IUI success rates are approximately double what they would be if you just place sperm into the uterus at home or do like an intravaginal insemination. And that's because the freeze thaw process with the sperm makes it a little bit less viable. So assuming that you're using frozen sperm from a sperm bank, you would be better off doing the IUIs just because it would give you a higher success rate. And donor sperm is not cheap to purchase, so it would be more efficient for you to use it that way. Doing an IUI is a pretty basic procedure that we do in the office, where we're just placing the sperm into a catheter, which goes through the cervix and into the uterus. It's like a pap smear to do that procedure. And if you have PCOS, we would also give you ovulation induction medications, most commonly Letrozole, to make sure that you're ovulating and to make sure that your IUI is being timed appropriately. Next question, will there be any webinars discussing unexplained infertility? I think we do have. If you search our YouTube channel, I think we do have a webinar about that. If not, I will let the marketing team know that you would like a webinar on unexplained infertility. It's an important topic. Next question, would you recommend Clomid or Letrozole? So that's a very good question. Both Clomid and Letrozole can work to induce ovulation in women with PCOS. Letrozole is preferred these days for a few reasons. The biggest reason is that it actually works better. There was a multi-center randomized controlled trial a few years ago, and these are the types of trials that are very expensive to do, but are really, really helpful because they give us very clear answers to questions as far as which treatments are best. So this particular study was done by the Reproductive Medicine Network. They took half of the participants and randomized them to Clomid. They took half of the participants and randomized them to Letrozole. And then they studied who became pregnant and what the live births were in the two groups. And that study showed that Letrozole had a higher ovulation rate than as compared to women who took Clomid, also a higher chance of becoming pregnant and having a live birth, which is what you care about, is having a baby. So you're more likely to conceive and to have a baby with Letrozole as compared to Clomid. Again, Clomid can work. It just works a little bit less effectively. The other concerns or considerations with Letrozole versus Clomid is that in general, it's better tolerated. Everybody's different, and the side effect profile is a little bit different between Clomid and Letrozole. The most common side effects of Letrozole are fatigue and headache. The most common side effects with Clomid are hot flashes and bloating. And then moodiness symptoms are more common typically with Clomid. More women have side effects with Clomid than they do with Letrozole. So in general, Letrozole is better tolerated. But again, everybody's different. If you try Letrozole and you feel terrible on it, we could always try switching you to Clomid. That's a reasonable thing to consider. And then the other consideration with Clomid versus Letrozole, twinning risk is actually a little bit higher with Clomid as compared to Letrozole. You see approximately a 5% risk of twins with Clomid and closer to a 3% risk with Letrozole. So not super high with either treatment, but it does appear to be a little bit lower in most studies with using Letrozole. So it's usually a preferred medication. Next question, starting IVF the end of September, is there a specific diet for this? Should I be avoiding certain foods? This is a very common question, and it's an important one. So I think having a healthy diet is important for everybody, and certainly important for women who are going through fertility treatments. The diet that can be important for women with PCOS would be to consider using a low glycemic index diet. So that means avoiding simple foods that have simple sugars in them, or simple carbohydrates. You don't have to avoid carbohydrates altogether or go on, an Atkins type diet. But you should try to make sure that the carbohydrates that you're getting are complex carbohydrates that will take the body a little bit longer to break down into sugar. That prevents the sugar spikes that you can get, that can typically worsen things like high insulin levels. And then low glycemic index diet would be something to consider. And then what's called a Mediterranean style diet, is the one that's been best studied in terms of health outcomes. It's kind of a misnomer to call it a Mediterranean style diet. And anytime I tell my husband that, he says, okay, great, so we can eat pizza because Italy's in the Mediterranean, but it's not exactly what that means. Basically, a Mediterranean style diet involves getting protein from lean sources. So getting proteins from things like chicken and fish as opposed to fatty red meats. It involves trying to avoid animal fats, and getting fats more from plant sources, so things like avocado nuts, getting fats, olive oil, getting fats more that way. Staying with complex carbohydrates as opposed to simple sugars. And then fresh fruits and vegetables are also important in that diet. So in general, I would try to follow that diet. Nobody has a perfect diet, so don't beat yourself up if that's the case. But if you're able to follow that type of a diet most of the time, I think that that's a healthy habit to be in, and will hopefully help you with your IVF process as well. Next question, what are your thoughts on ashwagandha supplement to improve PCOS symptoms or help to conceive? So the challenge with supplements is that they are generally not very well studied. So it's really hard to comment about what the benefits of supplements are, what the risks of supplements are, what drug interactions there could be with medications that we're prescribing for you, and what side effects you might have. So in general, I would be pretty careful with taking supplements. There's no known benefit that I'm aware of with taking ashwagandha to improve PCOS. So I would not recommend that you take that particular medication. I think being on a prenatal vitamin prior to conceiving is very important. The folic acid will help to prevent a specific type of birth defects in babies called the neural tube defect. So that supplement or vitamin is important preconception. I mean, you can try ashwagandha, but it's a little bit like doing an experiment on yourself. It's really hard to say whether that's going to help you or hurt you. So in general, I would try to avoid those types of things if you can. Next question, I have cycles that are sometimes consistently regular, 33 to 34 days, and sometimes several cycles that are 36 to 40. Could there be a reason for this? Also, can 3 cycles of letrozole back-to-back affect cycle length after going off of it? Letrozole has a pretty short half-life. So once you've taken it and if you haven't gotten your period, it should be out of your system. So I wouldn't expect that to be influencing your cycle length after taking the letrozole. It sounds like you are someone who ovulates some months, but not other months. And that is common with PCOS. And it does make it harder to conceive because while you may be ovulating and releasing an egg, sometimes it's not quite as frequent as it should be. So I think this is probably due to underlying PCOS. That's not an uncommon bleeding pattern. And again, some of those cycles you're probably releasing an egg and some of them you're not. If you've already tried the letrozole for 3 months, usually we would kind of take the next step at this point and consider adding IUI, which is placing sperm into the uterus, or doing something more involved like IVF to help you to conceive. If you're young and the letrozole is, working and helping you to ovulate, you could try it up to 3 more times. You just start to see a decline in pregnancy rates if you haven't gotten pregnant, usually within the first 3 to 4 cycles of a given treatment. So it might be worth a conversation to with your doctor about moving on to the next steps. Next question, is there a medication PCOS patients can take that helps regulate the androgen levels that is safe if I want to get pregnant? I was recommended to take spironolactone, but that is contraindicated for pregnancy, and I've tried metformin but didn't tolerate it well. My main concern is insulin resistance and hair loss. So to address the insulin resistance, if you did not tolerate metformin, you could consider taking Myo-Inositol, which is it is sold as a supplement in this country, and I know I just told you you should be careful with supplements, and you should. Myo-Inositol, however, is regulated as a medication in Europe, so we do have reasonably good efficacy and safety data about Myo-Inositol because it's been reasonably well studied, because it's again sold as a medication in Europe. So that is a good alternative. Generally, it would be 2,000 milligram dosing that we would use for the inositol, and that is pretty similar to metformin and how it would address the insulin resistance that you have. It does tend to be much better tolerated than metformin as well. When you're purchasing supplements, you want to be careful because supplements aren't regulated by the FDA or by anybody. So you want to make sure that you're getting a quality product. The couple things that you can look for, if there is a stamp on the back of the bottle that says either NSF or USP, that means that the supplement has been verified by a third party to contain what it's supposed to contain. So if you're going to purchase something like Myo-Inositol, looking for that stamp is important. Theralogics and Nature Made both have good brands. Their products are typically verified. So that would be something to consider for the insulin resistance. The hair loss is related to androgen levels. Spironolactone is effective in reducing androgen levels, but it is contraindicated during pregnancy. Unfortunately, there's not a lot that we can do to address high androgen levels while you're actively trying to conceive. Taking something like a birth control pill or progesterone will lower the androgen levels fairly effectively, but obviously that's not going to help you to become pregnant. So unfortunately, there aren't a lot of options for that while you're trying to conceive. But when you're between periods, or between pregnancies rather, not between periods, when you're between pregnancies, going on something like birth control pills can be helpful for you as well as the spironolactone. Next question. I am considered high risk and not recommended to get pregnant at the moment. Is there a way to get a consult with you bypassing the 6-month trial period? We can certainly talk to you at any point. If the concern is that you're a high-risk pregnancy, we help you with the getting pregnant part. But meeting with MFN, with our maternal fetal medicine specialist consultants, can be helpful to determine why you're high risk and how we're going to manage the pregnancy. So that is definitely something that we would do with anybody that we would consider to have risk factors. Our role is to help you to conceive. So if you don't have trouble conceiving, then you don't necessarily need our services. But if there is something going on that's going to make it hard for you to conceive, then yes, we can certainly obviously discuss that and talk about what treatments would be best for you. So did I say that women with PCOS usually have a lot of eggs? Usually, yes, but not always. Number of eggs in the ovaries is largely determined by age. When we do IVF on women with PCOS, often we do see very high egg yields, but that's not always the case. Number of eggs in the ovaries will decline as a function of age. Before you start any sort of fertility treatment, we would usually do testing for you to see how many eggs are in the ovaries. That's measuring what's called the ovarian reserve, which tells us the number of eggs that are there. And that is helpful in determining how well you would respond to fertility treatments. So yes, many women with PCOS have lots of eggs to work with, but that's not always the case for everybody. You mentioned Myo-Inositol. Is that a supplement that can continue to be taken after getting pregnant? If not, how can I keep PCOS in control during pregnancy to reduce miscarriages? So Myo-Inositol, we don't typically continue into a pregnancy, so that's another medication that we would usually stop with a positive pregnancy test. Things that you can do to keep insulin under control would be to follow a low glycemic index diet, a diabetic diet, will help to prevent those spikes in blood sugar that should hopefully help to reduce the risk of miscarriage. You should also be screened early in the pregnancy for gestational diabetes. If you have gestational diabetes during pregnancy, most commonly that would be managed either with diet, and if diet is not enough, then we would usually use insulin. Typically, oral medications are not used to treat gestational diabetes. It's usually insulin that is used during the pregnancy because that's the most effective and the safest choice. Next question, are there any risks with ovulating late after day 21 and trying to get pregnant? I mean, you can still get pregnant with a very irregular cycle. If you release an egg and there's sperm available, then there's certainly a chance for pregnancy. And women with PCOS with irregular cycles can and do conceive despite having an irregular bleeding pattern. It's just less likely that you're going to get pregnant, and it's harder to time relations when you're actively trying to conceive. So you can still try to get pregnant even if you're ovulating late. It's harder just because you're having fewer chances to get pregnant every month, but it is still okay to try. It's not harmful if you release an egg and there's sperm available, pregnancy can occur. Do not assume that your PCOS is birth control. So if you don't want to become pregnant, using something to prevent pregnancy is still recommended for you, even if your cycles are irregular. Next question. I have been told to take folate while trying to conceive, but then I heard that a large percent of women with PCOS, it actually works against us. Can you please clear that up? You should take either folate or folic acid prior to conceiving. That should not mess up your PCOS. And it is important in preventing birth defects in babies. So there's a specific type of birth defect in babies called a neural tube defect. And folate or folic acid reduces the chance of that happening. There is a small percentage of the population that doesn't metabolize folic acid as well as folate. So a lot of prenatal vitamins these days will have folate or 5-methylfolate as opposed to folic acid. That's fine for you to take. And again, some people metabolize that particular one better. But I think it's misinformation to say that you should not be on folic acid. I think that that's pretty important for you while you're trying to conceive. So either folate or folic acid, dose of at least 800 micrograms. It's okay to take a higher dose than that. These are B vitamins, so they're water soluble. So they're not toxic. They don't build up in your system. If you're taking too much, you just pee it out. So it's okay to take higher doses of both folic acid and folate. People with the MTHFR mutation are the ones who don't metabolize folic acid as well as folate. If you're concerned about that, we can do a blood test to see if you have the MTHFR mutation, or you can just take folate. Either approach is okay. Next person says, I am currently pregnant with twins after IVF. Congratulations. And have PCOS. Should I worry about miscarriage? There is some risk of miscarriage, but hopefully you will be able to successfully carry this pregnancy. There's not really a lot that we can do to reduce the risk of miscarriage. It will usually happen or it won't happen. And I know that's hard to not have control and feel like you can do anything about that situation. But I wouldn't worry that you're going to miscarry. We will do an ultrasound for you, usually at about the 7-week mark. At that point, we're expecting to see babies that are appropriately grown with a positive fetal heart rate. If we that, then the risk of miscarriage is reduced. There is some risk that a twin pregnancy will reduce to a singleton pregnancy. You can see that up to 25% of the time. so a repeat ultrasound later in the pregnancy just to make sure that both embryos are still growing would be reasonable for you to consider. But I hope that you will carry the pregnancy, obviously, and not miscarry. Not miscarry. Try to focus on the things you control, having a healthy lifestyle, taking a prenatal vitamin, and good luck. I hope your pregnancy continues. Next question. I have PCOS. Periods are as irregular as 70 to 100 days apart and always a different amount of time. From period to period, will I typically ovulate always 2 weeks before my period, or can it occur anytime in between periods? So if you're ovulating, it would be happening 2 weeks before you're getting your period. You're not ovulating in the middle of that stretch, because what happens when you ovulate is that your ovary makes what's called a corpus luteum cyst, which produces progesterone for approximately 2 weeks. And then if pregnancy does not occur at that time, then the corpus luteum dies and goes away and the uterine lining sheds, and that's when you get your period. So if you're not getting your period, then you're not ovulating in the middle of that time. You might be ovulating 2 weeks before you're getting your period. You might not be, though, with that long pattern like that. What can happen is that you can get anovulatory bleeding with PCOS, so the lining of the uterus builds and builds and builds, and then it just hasn't shed in a long time. So eventually it just sheds kind of on its own, even though you haven't actually ovulated. So you're probably not ovulating most of the time here. So if your goal is pregnancy, some sort of oral medication would be a good idea for you to consider if you want to get pregnant. Next question. What's the chance of getting pregnant when you guys actually place the sperm into the egg? Is that process usually always successful? It sounds like you're talking about IVF with what's called ICSI. ICSI means that we're injecting a single sperm directly into the egg. That is a technique that we use in the lab to overcome sperm issues or fertilization issues. It is usually very effective in achieving fertilization of the egg and the sperm together. From there, embryo development varies. So some embryos progress, some embryos don't progress. If you make it to getting a good quality embryo, especially if we've done PGT testing to make sure that it's chromosomally normal, we typically see about a 60% chance of successful pregnancy with transfer of that embryo. So fairly high chances of becoming pregnant if you get to that point. There's lots of things that influence success rates with IVF, and there's some calculators we can use which will estimate what your chances and probability of success would be with IVF. That's based on multiple factors. All right, so we have about 3 minutes left, so I'll take a few more questions and then we'll wrap it up for the evening here. How can I determine my testosterone level, and how can I reduce my testosterone level to improve fertility and ovulation? So you can determine your testosterone level by doing a blood test, and that will tell you whether it's elevated or not elevated. There's not a lot that you can do to ovulate aside from using letrozole or Clomid, which is going to be the most effective way to improve your fertility and to help you to ovulate. And that taking the letrozole or Clomid will regulate the hormones, and that'll drop that testosterone level so that it's not creating the issue and the problem for you. So ovulation induction would be the best approach for you there. All right. Why don't I do, excuse me, one more question and then we'll wrap it up here. So the last question I have is, if I have PCOS with about 4 periods actual bleeding per year, why do I still get other period symptoms like cramps, cravings, headaches without bleeding? I'm sorry that you're getting those other symptoms. It's hard to say why you're having other symptoms like that. If you go on something to regulate the periods, you might just have more consistent hormone levels, and so that might address some of the issues and the side effects that you're having. So using like birth control pills will give you a more consistent amount of hormones, so there aren't the peaks and the valleys that you might be seeing. So that would be reasonable to consider. And then you may want to have some other testing done to make sure there aren't any other hormonal abnormalities that are causing that. So checking like your thyroid hormone and checking glucose testing would also be reasonable for you to consider. So, let's see if there's. And how long do you have to wait after an egg retrieval? Can the egg be implanted with PCOS? All right, so this will be the last question. This is asking about management during an IVF cycle. So in IVF in women with PCOS, we most commonly are going to freeze your embryos to let your hormone levels come back down, and then make sure the hormones are at a physiologic normal range before we transfer the embryo. So usually we would do an egg retrieval procedure. And then if we're doing PGTA testing, it takes a couple weeks to get those test results back. So we meet back about 3 weeks or so after the egg retrieval to go over the test results. And then assuming you have a normal embryo, would move forward with transferring that embryo back to the uterus with a frozen thawed embryo transfer cycle. So that's usually the best approach. There are some women with PCOS who can do what's called a fresh embryo transfer, where we transfer the embryo back to the uterus in the same cycle where we've done the egg retrieval procedure. But for many women, you might have a lower chance of becoming pregnant with that approach with a fresh embryo transfer. And you would also potentially be at risk for a complication called ovarian hyperstimulation syndrome, which I talked about a little bit earlier in the webinar. So typically frozen embryo transfer is done in women with PCOS, but that's not universally true. There's lots of factors that would go into making that decision that you can certainly talk about with your doctor. So I think that we're at 8:01, done on time. So I appreciate the opportunity to talk to you today. If you're having trouble conceiving, definitely encourage you to make an appointment with one of our physicians at Boston IVF. Would be happy to help you with your fertility journey and hopefully get you on the road to parenthood. So thanks for joining me today. Hope you guys have a good rest of your evening. Take care. Bye.